In thinking about the mental health needs of healthcare workers in the setting of this COVID pandemic, there's a couple of different phases. So one was the run-up phase where everyone was just sort of plunging in really the sprint. And I would say no one really thought about mental health then. Everyone was so driven. Then there was the middle phase, which you can either call the plateau or the abyss, depending on which way you look at it, because it really was both. And that was a very sort of long slog. And I think that's when many of the issues began to come up for people, but there wasn't really time to think about them or process them. The issues that came up during the most intense part was the shock of how sick patients were and how quickly many patients died and how fast things were happening. And there really wasn't much precedent for that. I mean, those of us who trained during the time of the HIV epidemic had familiarity with that sort of intense death and destruction feel. And I look at our trainees now, and this was completely new for them. And so there was a very different sense of those who've never been at that before to see your patients really mowed down at rates that were staggering and in manners that were staggering. But even for those of us who experienced HIV, this was still, the pace was much more intense. It was like I think of it as the HIV epidemic crossed with Hurricane Sandy and that sort of intense time pressure all together. And that's the thing that I think we need to recognize, that many people in healthcare of the sort of younger generation haven't seen this at all. And so many people have seen a few patients die in their career or over time, but not tens and dozens and that sense of that. And that's really quite existential, I think, for people, nurses, doctors, healthcare aides who really haven't faced that and really thought about what does death mean. And so I think the first thing is just to approach the sense of what it means when you see patients die. If you haven't been in a war before, and I think military doctors may be more prepared for this, but civilian doctors really haven't. In terms of how mental health care practitioners can assist with that, part of it is just bringing up the conversation. Because during the whole time, and honestly, even now, there isn't a lot of space to talk about it. I think people are talking in little bits and corners and hallways and offline, but there hasn't been sort of an honest reckoning of what it is meant to be in this sort of sea of what feels like death and destruction, particularly because the death and destruction feels divorced from what the rest of society is seeing. Everyone else, they may tune into their governor's, briefings, and they see the charts and they see the numbers, but they haven't really seen those patients. And it's quite a different feeling. And I, think a lot about the people who are protesting the lockdowns now. And I have sympathy for them. Obviously, being cooped up is really hard. But if you have never stepped inside the ward or the IC or the emergency room, there's no connection to what's there. It's just this number or this order you can't move out. And so the disconnect of the experience that the healthcare workers having compared with what their friends and family might be experiencing, what the general public is experiencing, is quite vast. So I think a starting point is to recognize that in many ways, healthcare workers feel a little bit isolated from the rest of society, that we're seeing this, but no one else is. And it's very hard to kind of jive those two experiences together. One unique part of the COVID crisis was the rapidity with which patients declined and the absence of family members to help those patients. And normally, when patients are sick and ill and dying, patients have their family, they have other people at the bedside. And so the sense of loneliness was very powerful, and healthcare workers were pulled into this role where they normally do. I mean, nurses and doctors are empathetic and they step in and help, but usually they're also assisting family members and social workers and chaplains to be there. And in this case, really no one could. And so healthcare workers ended up being much more closer to the emotional bone, whether it was by using their phone to, FaceTime with family members or being the only one. I'll share with you during mid-April, when it was really the depths or the height of it, I was helping out in the emergency room, and we had one half of the ER was now another ICU. So I was working there, and the patients were just sort of lined up open ward style, everyone on a ventilator. And part of it was just the chaos of that. We had tons of nurses and doctors from different services, different hospitals, visiting from Ohio. We had ventilators donated from everywhere. So there's a bit of a chaos feeling. And there was one patient whose temperature kept rising, that like I've never seen it. 104, 105, 106, 107, 108. 108.8, which I didn't even know was compatible with life, but it was. And so we were racing around to get ice packs, and we had to put in an arterial line in her wrist, but her wrist was really swollen. She had all these little braided bracelets on, and we had to cut them off. And I cut them off with a suture scissors, and I put them in a specimen bag. And I thought, what am I going to do with these? And so I stuffed them under the bed with her stuff, and I thought, I hope her family gets them. And part of me thought, should I keep them in the event of, but it was so chaotic. Would I lose track of this patient? I wasn't really on her team or helping out. So I just left them under the stretcher. And a couple of days later, she died. And I wondered if those bracelets ever got back to her family, because I remember as we were cutting them off, the resident and I were looking at them, and the resident said, this is like the last bit of what's really her. Everything else is gone. Her clothes are gone. Her personality's gone. She's at this point intubated and paralyzed and sedated. And this set of about 8 different bracelets, different colors, braided, those friendship bracelets. And I regret that I didn't keep them. Of course, I wasn't supposed to do that, but I should have broken the rules, kept them, kept her name, and then I could have put them in an envelope and mailed them to her family. And I didn't. And I think everyone has those sort of regrets of those little things you could have done, tiny things, but too much was happening. And I think those small things become vehicles or places where we put all of our anxiety and those silly little bracelets, everything that I regret about what I could have done better or more for my patients or worked longer hours or whatever we could have done, come into that. I think everyone had a sense of we weren't doing enough. And so if you were, and now of course it took many different roles to make this work. I mean, lots of people had to stay home in their houses and call the thousands of patients who couldn't come to keep them out of the hospital and keep them healthy. But those doctors and nurses felt really guilty. They weren't in the hospital helping the patients. And those who were in the hospital felt guilty they weren't in the ICU. And those in the ICU felt guilty they weren't working overnights and 24 hours a day. And so everyone had sort of sense of guilt. They weren't doing enough. And even when you were doing the most, but you got your day off, you're like, I need to go in. I need to check the medical records from home and see what I can. And all of us felt sort of consecutive levels of guilt of not doing enough. I think we need people to speak openly from the top. I noticed a resident posted on Twitter about the stress she was having. And then she said, but I spoke with my psychiatrist and I'm feeling better now. And I was so impressed that she came forward and said that. And that's really destigmatizing. And so we need the chairs and the medical directors and the hospital thing talking about, oh boy, when I spoke with my therapist or my social worker or my psychologist or my psychiatrist, boy, that was really helpful. And it's stressful now. So I'm seeing my therapist every other week or I'm having phone calls, something, from the top down, that again, it is just part and parcel that it would be, and to make the point that it would be, we'd be harming our patients if we didn't care to this part of ourselves. Just like we all get our flu shots and we get them because we don't want to spread flu to our patients. And so tending to our emotional needs so that we can take better care of our patients. We don't want to harm our patients by bringing in, poorly adapted mechanisms from some other stressful period that we didn't ever handle. So I think that walking the walk beyond just talking the talk from the top down would really help to destigmatize this. It's hard to predict what the long-term mental health consequences will be. I remember after 9/11, we thought about that this would be really sort of permanent scarring on patients, on staff, on the community. And it seemed we would never heal from that. And it was amazing to look back and see that people somehow managed to do that. And I think they will again from this, and the same with AIDS, the same with Hurricane Sandy, and all the various calamities and tragedies that we've faced. I think the recognition that it is a marathon and that, COVID will certainly be there, even as we release from the lockdowns and get past this peak, it's not going away. It's not going to disappear. And so it'll be there in the fall when people's attention are on something else. And I think maybe mental health, maybe healthcare workers will start to feel a little bit ignored then. Like, oh, we're onto something else. We're onto the elections. But we're still battling COVID here. And so maybe setting systems in place to be there in the future, recognizing that there will be, effects. What those effects are, hard to say. But certainly, I think many trainees and younger healthcare workers were very frightened by this and maybe don't have a language to articulate that and or how that might affect their choice of career, the choice of how they practice, what they ultimately choose to do. You may be influenced by this, and we'll need people there to just help sort of guide that sort of amorphous anxiety and distress that's come from this that we may not yet know where it lands. And then the other thing I'll put a plug for is the role of humanities and the arts in dealing with all of the emotions and in helping us smooth the edges of our practice. I'm slightly biased because I'm going to bring up the Bellevue Literary Review. This is our literary journal we publish from Bellevue, and it's fiction, poetry, and creative nonfiction about health and healing, open to the general public. And we publish twice a year poetry, and we try to find things that people would find helpful to think about, things you might not have thought about. The first patient who died on you, the first time you were afraid, and using creative ways. And I think that music, art, literature really play a role. So much of medicine presented in the textbooks feels very straightforward, but the practice of medicine is filled with ambiguity in shades of gray. And we have such discomfort with ambiguity in medicine. We want, evidence-based medicine, but real people and real conditions are very ambiguous. And so it's profoundly unsettling. And we don't get much training in how to deal with ambiguity. But great works of art and literature and music specialize in ambiguity and shades of gray. That's what makes them so fascinating and interesting. Dissecting metaphors and poetry is a way of looking at the complex things that don't fit into easy boxes. So I would certainly, encourage all of our efforts, mental health efforts, wellness efforts, to incorporate the arts, music, literature, and the humanities, because they treat a part of the issues we're facing that don't come in through the journals and textbooks.